When you hear the word dementia, when you hear the word Alzheimer's, what do you think of? 55 million people go through this daily. Seniors struggle with this. Your loved one struggles with this. Everyone struggles with this. But has anyone taken the time to break down specifically what happens in the brain and how it affects seniors? And how it actually reverts them back to almost becoming like toddlers.
I had one lady that I remember, she was in the hallway repetitively hollering out, "I want a cookie, I want a cookie, I want a cookie." So I went and found a cookie and gave her her cookie, and then she threw it across the room and then said, "I don't want a cookie, I don't want a cookie, I don't want a cookie." I think eventually we ended up getting her calmed down, but sometimes you do just have to kind of go with the flow and roll with the punches, and they do make you smile.
In this episode of Charlin Care Pods, we have a special guest, Carley Stiglets, nurse practitioner, who's going to walk us through what dementia is, what Alzheimer's is, and really help you and your family understand how to take care of them. What's up, Carley? How are you?
I'm very good. Thank you.
Thanks for coming on. I appreciate you hanging out with us today and talking about something that we talk about a lot, which is dementia and Alzheimer's. You've seen a lot in your years working with seniors. So if you don't mind, tell us about yourself just in general, and love to hear more about what you do.
Yes. So my name is Carley Stiglets. I am a nurse practitioner. I have been working as a nurse practitioner for 24 years. Nice. I have worked in nursing homes for about 15 years. And then after that, I have worked in memory cares, assisted livings. I worked in independent livings. I have also, for the last 3 years, done work with Charlin and hospice care. And have recently started doing some work in palliative care. Nice. And all through that, I have always been involved with geriatric medicine and have always dealt with patients that have dementia and Alzheimer's. So I really am passionate about working with patients with dementia. I really enjoy it.
That's cool. What got you into becoming a nurse practitioner, if I may ask? Just curious.
Yeah, I knew early on in high school I wanted to be a nurse. Nice. So I started my nursing career right out of college, and shortly thereafter I knew I wanted to go on and further my education, and started my master's degree and became a family nurse practitioner, which is kind of at that time kind of the foundation as a nurse practitioner. And I wasn't planning on initially going into geriatrics, but moved to Prosper, and there weren't at that time a lot of choices out in Prosper. It was a small community, so ended up working in long-term care and really just ended up loving older patients and loved the environment, and was able to make a very big difference in their overall health, and have stuck with geriatric medicine.
That's cool. It's like that's good to know, because I feel like there's a lot of areas that nurse practitioners can serve patients.
Yes.
You were saying long-term care, and then you mentioned also working with insurance too, right? Is that?
Yes.
That's cool.
Yeah.
That's pretty neat.
I worked with insurance companies and saw it was actually mainly older people in their homes that were high-risk patients, high risk to go back to emergency departments, hospital admissions. Usually those are patients that have multiple chronic illnesses on numerous medications. So a lot of education there, but
Wow. So I know we talk a lot about just, being in facilities and taking care of residents in facilities, and you see a lot of Alzheimer's and you see dementia. If you don't mind, just kind of break down what is dementia and what does it entail?
Okay. Dementia is actually an umbrella term. There's several different types of dementia. There are some that we actually don't see very often in older people, but there are several that we do see. The most common that we see is Alzheimer's. About 60 to 80% of dementia in adults is Alzheimer's disease. And it's estimated, and depending on different resources, but that Alzheimer's is the 6th leading cause of death in adults right now in America. And in the next 25 years, which is really a short time period, it's estimated that about 15 million Americans will have Alzheimer's. So it will more than double in the next 25 years, and it's simply because we're living longer.
Yeah.
So people are living longer with chronic illnesses like emphysema or heart disease or strokes.
Yeah.
We're living longer, so we're seeing more and more Alzheimer's.
Wow.
Yeah.
Wow. That's kind of crazy because I think a lot of people don't realize that you just said 25 years.
Yeah, that's a very short time period from now.
Wow. So how do people, how do they become aware that they have dementia? Or how does that even work? Or who diagnoses it? Or
Yeah. I think in the beginning, the important thing is if you do begin to notice memory gaps, that sort of thing, I think it's very important to see your primary care physician and be assessed to make sure there isn't any type of dementia. So in a primary care setting for healthy individuals, normally a primary care provider will rule out other causes of memory loss, such as B12 deficiency, thyroid problems, whether it's hyper or hypothyroid. They'll look at your blood counts as far as anemias, make sure there's no infection. They'll look at your liver, kidneys, if there's been any recent medication changes. So if you've recently been started on an anxiety medicine or a depression medicine, or maybe a new medicine, like maybe a gabapentin for a back pain, those possibly can change cognition. So they will look at those things and make sure that's not causing any memory loss. Then you would do a MRI or head CT and rule out, like if there's a tumor or if you've had a stroke, that sort of thing. If you're older and you've come into like a long-term care facility or an assisted living, and we were to see you and we recognize there's a cognitive deficit, we'll probably do those labs that I mentioned and send a urine. We don't always send people for head CTs and MRIs. It really depends on their overall health, because often doing that workup would not change their plan of care too much. But there are, once you are diagnosed with dementia, with Alzheimer's, there are medications, and it is very important you start those as early as possible.
Wow.
Yeah.
What are some of those, you mentioned some of those medications, what are some different types of medications that you usually see?
For mild to moderate dementia, there's oral medications, and those are what we see all the time. That's your Aricept, that's your Exelon, Razidine. Those have been around a long time. Recently, there are the newer medications that have been approved for Alzheimer's, and those are IV medications. Those are costly, and I'm sure insurance does cover some of that, but your neurologist or neuropsychiatrist would walk through some of the risks and that kind of thing with you. So normally in a long-term, if someone's in a long-term care facility or assisted living, they're not going to be an appropriate person for those IV medicines, because they're probably in the later stages of Alzheimer's. For moderate to severe dementia, there are, the most common medicine is Namenda. And, the important thing to know about these medications is they don't cure dementia. They slow down the progression of memory loss. So we often, healthcare providers often will hear that a patient or a family member may recommend that their loved one quit taking the medication because they haven't noticed an improvement. But that's not actually how the medication works. It slows down the progression. So you don't always notice an improvement. With Alzheimer's, there's formation of plaques and these neurofibrillary tangles in our nerve cells, and it slows down the progression of these plaques and these little tangles in our nerve cells, so our nerves can continue to communicate properly. So we're supposedly, these medicines, if you stay on them and you started them early, will give you maybe, hopefully, 1 to 2 more years of independence that maybe you would not have had if you never were on them, which is significant in quality of life, and also cost, because I mean, these assisted living facilities are now becoming more and more expensive. I mean, people can spend $50,000 to $100,000 a year on a facility. So if it gives you 1 to 2 more years at home, that's very significant for quality of life and cost for family.
What parts of the brain, we're talking about just the medications, but in terms of dementia, what parts of the brain are affected by dementia?
Yeah, so the different types of dementia, that's how we classify the different types of dementia depending on where the brain is affected. So with Alzheimer's, you know, I'm going to back up a little bit. So we, as far as our brain goes, we have different parts of the brain. The main part of the brain is the big areas here is our cerebrum, and it's divided up into lobes. We have the frontal lobe, the temporal lobe, which is right by our ears, parietal lobe, occipital lobe, and then underneath, it's in the back, kind of between our ears and the back, is the cerebellum. The cerebrum, the main cells there are our neurons. And unfortunately, the neurons are the main cells that Alzheimer's does affect. And neurons control our thinking, our problem solving, our emotions. The cerebellum down here, Alzheimer's also affects. Neurons are also in the cerebellum, but controls our balance, our coordination. That's where our language processing is. So that's why they have difficulty finding words, or maybe the wrong word comes out, that sort of thing. So Alzheimer's, and this is a picture of the different neurons, of healthy neurons in the brain. So here they connect, and they are supposed to just, one neuron to the next, just communicate smoothly. When you have Alzheimer's, these protein build up. These are the amyloid plaques. They form in between these neurons, so there's no longer good, smooth communication. So there's going to be, your thought processes are going to be distorted. So maybe that's where some paranoia comes into play, because your thought processes aren't appropriate. Smooth. Right, it's not smooth. Feelings can be interrupted. So maybe you're showing your feelings inappropriately. So maybe you can cry, but you're really not sad. But you have to, look at the whole scenario. You could also truly be sad. But if you're crying and you're visiting with a friend while you're painting, but you're crying, maybe you're really not sad. It's just an inappropriate expression of a feeling because of Alzheimer's. Right. So again, here's the plaque, and then within the neuron cell here is the neurofibrillary tangles. So again, both of those processes decrease communication in the brain. And then over time, with decreased communication in the brain, your brain actually does shrink with Alzheimer's. Yeah. And with Alzheimer's, healthcare providers, we stage Alzheimer's, and the purpose of staging Alzheimer's is just to gauge where someone is in their disease process. People with Alzheimer's don't always follow the stages exactly, but it helps give whoever you're communicating to an idea of where they are. Briefly, stage 1 is normal cognition. Stage 2 and 3 someone with Alzheimer's stage 2 and 3, they can still hold a job and they can actually still drive a car. Yeah, so they can still function pretty well. They may notice memory gaps. So this is when we said earlier, if you notice a memory gap, you should go to your primary
PCP.
care physician and have it checked out, because you're aware of it at this point. You've recognized it. So if I am at church on Sunday, for example, and someone comes up to me and says, "Hey, I saw you at the grocery store on Wednesday, your son was so cute," and I didn't remember
Genuinely,
seeing them. Yeah,
Wow.
that's a gap in memory, and that is significant. And I use that as an example because just because we walk into a room and kind of forget what we went in there for, we all kind of do that sometimes.
Or keys, you forget where you put your keys.
You forget where you put your keys. Those really are just, we have too much going on, or we got distracted. That's really not necessarily a worry for possible dementia. The exception to the keys is if you find your keys in a really odd place, like you've stuck them in a refrigerator.
Oh, wow, yeah.
That would maybe be a red flag.
Yeah.
So that
Next
would
to
be
the cheesecake.
right. Maybe you were grabbing the cheesecake right and left them in there. So I don't know, but yeah. So that's stage 2. Well, excuse me, stage 2 and 3. Yes, and then stage 4. As you progress, just that higher level of thinking is beginning to become affected. So planning is affected. So I think of just planning like your menu, your dinner menu for the week, putting what you need on your grocery list, being able to find it at the grocery store, and bring it home, that whole process. You would not be able to do that properly. You wouldn't be able to pay at the restaurant appropriately.
Like steps, like normal steps.
That's higher level functioning, thinking, processing. So you would have mistakes there. Stage 5, they would still recognize their loved ones. They still usually would live at home. They would start forgetting what day it was. They would get their days mixed up. They may come out, they would dress themselves, but maybe inappropriately. They would have a sweater on in the summer or vice versa, or come out with their clothes on, the shirt on backwards or not buttoned properly. So just needing more assistance. Stage 6, things continue to decline. Usually and again, people don't have to follow exactly, but usually this is where people start having problems with some urinary incontinence, because again, it's a decreased communication, from our brains telling that our bladder's full, so we don't know we need to go to the bathroom, which is a big issue for families. That's usually often a time where they start needing assistance in the home with urinary incontinence. They may begin to wander, so safety issues are a big deal. They may sleep more or sleep less. Behavior, some of those kind of things can start to arise. And then stage 7 is continuing to progress. This sometimes is when healthcare providers will gently begin to discuss if hospice is appropriate. Usually there is problems walking at this stage, because as Alzheimer's has progressed, usually it is affecting our cerebellum now, which is balance. So falls have started, and that's real important for families to know, even early on, to expect, so they don't get frustrated. They know that's part of the disease process, because balance is affected. It will probably happen. And then speech is affected, because again, that's part of our cerebellum. So as the disease progresses, they usually will speak less and less. So we watch for that. Swallowing. So we watch for coughing or food not going down properly. And again, that's as the disease progresses. So those are things we watch for with Alzheimer's. And there are a couple of other very common dementias that we see in
Yeah.
long-term care facilities.
Yeah,
You
like
want me to-
yeah, that'd be awesome actually. Yeah, like vascular dementia.
Vascular dementia we also is pretty common in long-term care facilities, assisted livings, memory cares, and now really even in people's homes. A lot of
Everywhere,
people
yeah.
live in their homes
Wow.
with caregivers, yeah. But about 10% of dementia, people with dementia have vascular dementia. And we sometimes, not all the time, but sometimes see vascular dementia after someone's had a stroke. So a CT scan might look like these little areas would be someone that may have had a stroke, so areas that have gone without blood flow. So some of that tissue has been damaged. And so risk factors to have vascular dementia would be high blood pressure, high cholesterol, smoking, obesity, or diabetes. You know, so if we have any of those diagnoses, we just want to do our best with tight control blood pressure, tight control cholesterol. There's a lot of programs out there to quit smoking, so we definitely try to encourage people to quit smoking, healthy diet, good control of their blood sugars to prevent. The interesting thing with vascular dementia is they also have memory loss, but usually it's a little bit further in the disease process.
Oh, wow.
We see more early on that higher level functioning loss first. So that planning, doing math skills,
more
so balance,
difficult.
that we see that loss first. So yeah, paying your bills, you might have errors.
Before. Wow.
Versus that's a little bit later in Alzheimer's. So that's one of the main differences there. Another type of dementia we see that's actually pretty rare, it's less than 1% of dementia patients, but is Lewy body dementia. And Lewy body dementia is really interesting. They, again, have memory loss, but the hallmark sign for Lewy body dementia is they have very vivid, well-formed hallucinations, but it's very early in the disease process. Alzheimer's also can have hallucinations, but usually it's several years into the disease process. Lewy body can be very early on. So in their, if they're diagnosed in their 60s, they can be in their early 60s and very vivid, sometimes scary hallucinations. I had a gentleman that thought he had alligators underneath his bed. And it was very scary. It can produce a lot of anxiety, a lot of fear. So they are significant. With Lewy body dementia, this is a neuron, like we had showed a healthy neuron, and these little areas are the Lewy body. So they're little proteins, and that's pretty classic for Lewy body dementia. So that's a diagnosis for Lewy body dementia. We do see Lewy body dementia in people with Parkinson's disease.
Oh, wow, I didn't know that.
But not all Parkinson's patients are going to get Lewy body dementia.
Gotcha.
They are separate disease processes, but we do see Lewy body dementia in Parkinson's patients. Lewy body dementia also affects body movement, so you do see the rigidity and slow movement. So just very kind of stiff and rigid body movements. They lose that fluid movements of their body.
Wow.
Yeah. So and then the fourth type of dementia that I'll talk about that we're hearing more and more about is it's called frontal temporal lobe dementia, and it affects the neurons in our frontal and temporal lobes. And our frontal and temporal lobes, controls our emotions, our personality, and our speech. And Bruce Willis was recently diagnosed with a frontal temporal lobe dementia, and his speech was affected. He was not able to communicate, and that is a piece of the frontal temporal lobe dementia. the sad thing with the FTD is an abbreviation for that, is it can affect really young people. It can affect people even in their 40s and 50s. And often we notice behavior changes, sometimes pretty bizarre behaviors and personality changes, and sometimes it's mistaken for maybe a mental illness.
Oh, wow.
But it's really a frontal temporal lobe dementia. So just for an example, if they may be watching just something on TV that might be a little bit funny, that maybe you or I might just kind of gently laugh at, no big
chuckle,
deal. Yeah, chuckle, and they may just over the top bust out laughing, kind of inappropriately. So, or they may laugh inappropriately at something very sad.
Wow.
Yeah, so their emotions aren't appropriate, and they can do kind of, just abnormal behaviors that aren't really appropriate in society. So people may think they have a mental illness, but with further workup, it can be.
Is that due to that kind of like plaque that you were talking about? Is it the same plaque buildup, or is it totally different?
That's related with Alzheimer's. Yeah, these are this is the neurons in this frontal and temporal lobe are affected. Yes, and it's affecting personality and behavior changes. And the other piece is the speech, and then they also do have motor loss in motor function. I actually had an aunt with frontal temporal lobe dementia, and she, towards the end, she was in a wheelchair, and she pointed. She was at our house at Christmas, and she pointed at our drapes at Christmas. So she recognized that our drapes were new. So she was cognitively aware, but she couldn't communicate, and she couldn't really control her body. So it's a very difficult disease. Yes.
So how do you care for residents when like, say for instance it's a facility, because you've been in so many facilities. How do caregivers, how do the aides there, how do they properly take care of someone who has dementia or like a really end stage Alzheimer's? What do they do? How do they help with that?
Yeah, taking care of patients with Alzheimer's or any form of dementia is very difficult, and I highly respect caregivers in the facilities. They work really hard. I think personally one of the best pearls of wisdom I could give a caregiver or a family member that's taking care of a loved one in the home, to really help someone with Alzheimer's or dementia, their quality of life, is really how, it sounds so simple, but it's very difficult when you live it day in and day out, but how we respond to that individual in their difficult time, whether it's when they're frustrated, when they're angry, when they're afraid, when they're anxious. It's really the response we give them. I think that's the biggest pearl of wisdom. And just as caregivers, just respond to them respectfully, do our best and respond to them in a calm voice, a caring voice, because the right words may come out, but they really respond directly to the tone, and just we all do. We all do the same thing. Yeah, sure. So just using a loving, caring tone, and it's common for patients with dementia, for example. Difficult times are often not wanting to get in the shower, and we try to be detectives and try to figure out maybe why they're not wanting to get in the shower. For example, it may be, make sure the water's the right temperature. Maybe their bottom is sore from being in bed all day. Maybe we can soften the shower chair, put a towel on the chair, make sure the water's not hitting their face. If all that is as comfortable as can be, brainstorm ideas. If they like their Snickers candy bar, give them a Snickers in the shower. If they enjoy their class, if they love to play piano play their classical music when they're in the shower.
Troubleshoot.
Yeah, just ideas. And really, they only need a shower in most scenarios. If once a week, that may be enough, and maybe just respect that and try again another day.
Yeah.
The other difficult time that sometimes patients have is, or residents have, loved ones have, is wandering. And, sometimes it's fine to wander, but it can be safety issues. So a good website, I try to tell family members, especially if they're in the home, sometimes in facilities it can be a little simpler because they have special units and stuff, but on alz.org they do have safety checklists to keep people safe, because they might in the middle of the night get in their mind that they want to go to work, and they often, it's a very common story, will go outside to go to work.
Wow.
So but wandering is a common scenario. It's super common. We try, if it's upsetting them, they're looking for something and can't find it, if they're wanting to go home, we try to say, hey, maybe that's something we can do after a good night's rest.
Yeah.
Or, look, it's almost lunchtime, let's eat lunch, and then maybe we'll talk about that. Redirect, right? Or it's very hot outside, let's wait until it cools off this evening and then let's talk about it.
Yeah.
But you're right. And then you could say, even if you know the answer to the question, how many children did you have? Okay, can you show me some pictures of your children? So kind of bring home into the scenario and have them show you pictures of home.
That's cool.
Or did you garden at home? That kind of thing, and help, redirect.
Bring them back.
Yeah, but you can talk about home.
Yeah.
The other common scenario is going to work. And so how can we help them work when they're wandering? So, and again, family is very valuable. I mean, they can help in facilities be very creative and help that. And often, residents do. It's when they do have downtime that they can get anxious and start wandering. And so how do we get them to work? If they're able to use a broom, give them a broom, let them sweep. A spray bottle with water and a washcloth. They can wipe a window or a table.
Do chores.
People love to clean.
That's true. It's therapeutic.
We can do plasticware, in a silverware organizer, or safe tools in a toolbox of some sort. But
that's cool.
Shoe polish, because in the day everybody polished their shoes.
Yeah.
And so just ideas to give them work. That's super valuable. Another issue that sometimes caregivers will have, or we have in facilities, is sometimes residents will want to take their clothes off in the halls or in public places. And I like to let people know there are now clothes that you can get online that do zip up in the back, and they look like a normal outfit from the front.
Oh, wow.
So they keep your dignity. They look nice from the front, but they can't pull them off.
Pull it off. Huh.
Which, so it's a simple fix. And then some people will just do basic overalls, just things like that. So just ways to prevent that. So you're not arguing, you're not telling someone, because I feel they do feel embarrassed when they're called out, and these are grown adults, and I'm a very big advocate on talking to them like a grown adult. And another interesting thing they have, and I believe it's quite expensive, but some facilities have purchased, it's called a Paro robotic pet seal.
What?
But it's a interactive seal, and there's all this research went into it, but it does interact with how, and it was, research was done with dementia patients, but how they pet and talk and how they interact with this seal. The seal responds in different ways, and dementia patients with behaviors, their behaviors got significantly better.
That's
so
pretty cool.
It's a neat device, but facilities often also use baby dolls and those sort of things if that's what that individual would be interested in.
That's pretty cool.
Yeah.
Wow.
So
I didn't even realize that. That's pretty neat.
It really is pretty amazing. Yeah.
Wow.
The baby dolls thing is cool.
Oh yeah,
And like the super realistic ones, it's crazy.
Oh yeah.
Yeah.
Maybe
So-
cry
Yeah.
Oh.
and the
They
cats.
actually like take milk.
Really?
Yeah. There's just like something inside of it that catches the milk. But yeah,
Oh wow. I didn't even know that.
super realistic.
Wow.
Another behavior that's very common in patients with dementia is sometimes they'll ask the same question over and over. And sometimes it's really not about the question. Sometimes we need to respond to the emotion, and often it's simply anxiety. They're feeling anxious. So if we can just respond, Miss Smith, we're going to take good care of you. It's almost lunchtime. You don't have to worry. I'm going to get you to lunch. We're having chicken. We're having green beans. It's going to be wonderful, but don't worry. We're going to take good care of you. Really, that's all they need to
That's
hear.
all I need to hear. Yeah. Reassurance. kinda.
Yes, absolutely, reassurance. What we don't need to do is tell them, I already told you that.
Yeah.
Because again,
Or like stop. Or something, yeah.
right. Because they don't remember they told you that their neurons are not connecting. They don't remember. And again, they recognize your tone and they feel like they've gotten in trouble. And that is quality of life, is just treating them respectfully and lovingly. And through some of those websites, there are support groups, there are many resources, educational tools. There's a lot of information in the alz.org, and it would benefit families, caregivers to look into that website immensely.
Wow, you saying that reminded me of like my 5-year-old always asking me the same questions. But it's like in the same way, their synapses aren't firing
That's
consistently too,
Right.
Because they're growing into it,
Right.
But at the same time,
They're impulsive and then same, that's
wow,
right.
because I just thought about him. I was like, oh, he asked me like, he just wants to be reassured. Like,
That's right.
yeah,
Right.
wow,
Like I'm going to be okay.
Yeah.
I'm safe.
yeah,
That's right.
What's that quote? Twice an adult or twice a child. Have you heard that quote
Yeah,
before?
I think so.
Twice a child, once an adult, or something like that. Yeah, that's a good point. Wow. Yeah, that's really good. It's a lot of good stuff.
What are some like big misconceptions that like families of patients, patients with Alzheimer's or dementia might have that are like really common? Or are there like common questions they immediately ask when diagnosed?
I think the one that you said earlier was really good. You were mentioning about that the medication is actually going to heal them.
Yeah.
Yeah, like
it's going to
Get them
they're going to
better.
get better.
Yeah.
Okay, so that would be one. Something to the effect like, we really don't want to be so aggressive in our treatment. For example, what I'm really trying to say is we don't want, like if your cardiologist wants to send you for a stent or something with anesthesia, you may not bounce back after your cognitive decline. You're like, misconception, I'm thinking like, because of your cognitive decline or your deficit, you may not rehab appropriately. Do you know what I'm trying to say?
Yeah, I do, yeah. That
so your
prognosis may actually
misconception-
get worse.
Yeah, it's just because you're cleared for surgery doesn't mean you're going to do okay.
Yeah.
It means you'll get through surgery.
Yeah,
You know what I'm saying?
Right,
But because of the dementia, you may not get out of bed because no, leave me alone. You know,
Yeah,
something like that.
like the effects of it actually make that possible procedure worse. And I feel like we see that a lot too. Is like,
Oh, it drives me nuts. Like, just leave them alone.
yeah,
I mean,
just let them be.
and they think I'm the dumb one because I'm not the cardiologist.
yeah,
and they have a super smart cardiologist telling them, they're clear, go. I'm like, "What?"
That's the effects of it are long lasting. That's a really good question.
This kind of goes with that, but like with family dynamics and with that where there's like the family Like, how do you deal with those tough conversations where the family's just like, yeah, we want to go with that, but you know in your heart that it's not the best for the patient?
Yeah. When a family has been recommended by a specialist to maybe that a procedure is recommended for a patient's heart or maybe a gastrointestinal procedure that would require anesthesia, for example, I try to share my opinion.
Yeah.
Having taken care of people with dementia for a very long time, I've seen often they will do fine through the procedure, but after the procedure, because of the anesthesia, they're in a different environment. They are seeing new faces they haven't seen before. So they will maybe wake up from the anesthesia and be very confused, and you cannot reorient them with just your words or a family member because they're afraid, they don't understand what's going on. So the staff, which is the right thing to do in a hospital setting, they might give them medicine to help calm them down, which is appropriate in that setting. But again, when they wake up, again, they're still going to be confused. They might then try to get out of the hospital bed without asking for help. They don't realize they're more weak because they just had anesthesia and then a medicine to help calm them down. They fall, they fracture their hip, then they are in the hospital, then they're rehab. So the smallest little change in anything can really redirect their path.
Yeah.
So I try to paint that picture for families to help them make a very full, informed decision, because it's not really about the procedure. It's really about after the procedure and their cognitive deficit, how it really can make such a big change in how they recover from even the smallest things. I've had people that have dementia have a minor skin procedure. This one particular patient, it got infected, which is common if you live in a facility.
Yeah.
She was put on antibiotics by the dermatologist. She became nauseated from the antibiotic, which is also very common. So she didn't eat good for a couple of days. She stood up out of her wheelchair, got lightheaded and dizzy. She was probably dehydrated. Fell, broke her hip, went to the hospital because she had a little lesion removed from her wrist. So the littlest things
can snowball.
Can snowball. So I try to tell people really keep things very conservative to help improve quality of life. For people with that cognitive deficit.
It's almost like I feel like patients, like you said, with that cognitive deficit, it creates those other things exacerbate it even more, maybe to some extent.
A large percentage of patients with dementia never get back to their baseline when they get back to their facility. They never get back to where they were once they went to a hospital setting. They don't get back. So
that's really good.
And a lot of families don't understand that, and a lot of healthcare providers that only work in the hospital setting really don't fully understand that because they don't see it, and that's fair. But that's why you hear people from all different perspectives and make a full informed decision.
Wow, that was a good question.
That was.
This is just random. I don't know if you do have one, but do you have any favorite patient stories? Funny patient stories? Anything? And on a light note.
I had one lady that I remember. She was in the hallway repetitively hollering out, I want a cookie, I want a cookie, I want a cookie. So I went and found a cookie and gave her her cookie, and then she threw it across the room and then said, I don't want a cookie, I don't want a cookie, I don't want a cookie. And then I tried to take her outside to sit down with her because she was a little upset, and we went outside, and and then she started hollering, I want to go inside, I want to go inside, I want to go inside. And I think eventually we ended up getting her calmed down. But sometimes you do just have to kind of go with the flow and roll with the punches. And they do make you smile, though. They often, and then sometimes they don't quit wanting to kiss your hand or
that's so
bite your hand or whatever. So it's fun. It's never a dull day. Never the same day twice.
Never at all.
It's a joy, though.
Yeah. Oh man. That's.
Do you have a piece of advice for a medical or a healthcare professional going into this kind of care setting, taking care of patients with Alzheimer's or dementia? Like one thing you would tell them, or even the families.
My biggest advice, and this sounds so fundamental, but so many people do not do it, would be just to simply educate yourself on dementia, because it would help you in how you respond. Because if you have an understanding of why they are doing some of the things they do, maybe it would help you be more empathetic. They're not doing certain things to be stubborn. They really, maybe forgot that you didn't want them to go to the pantry and make a mess, or, and we say their filter is gone, so they will just say things, their first thoughts, and it's very difficult not to let things hurt your feelings, but just to try to remember it's the disease process. But that's too why those support groups, those educational tools, all those are so important, because how we respond affects how they respond, and it is
a cycle,
and it's all connected. So it's really just getting yourself connected, and taking those breaks, if the caregiver, I always say, if the caregiver goes down, it all goes down. So caregivers do have to take care of themselves somehow. It is okay to take a little break. And in all reality, even if there is a little cognitive decline in your loved one, it's still okay for the caregiver to take a break. And the loved one is honestly not going to remember. And the caregiver's going to be back and still having quality time, with that loved one, because I know sometimes caregivers struggle going away for a day or two, or
that's
whatever
really
the
true.
respite is for that
that's
person.
Really true. Like the guilt almost,
Right, exactly.
Wow.
But it is valuable.
Yeah, that's good. That's good. Good job. Good job.
Hey, this is Charles with Charlin Health Services. Hope you enjoyed the video. Please remember to like and subscribe. We hope this was a blessing to you, your family, your loved ones, all your friends. Share it. And if you want to watch more videos, here they are. Enjoy, and we'll see you guys next time. Peace.